Welcome to Cutting Edge Health. I'm Dr. Orlando Landrum, and today we're going to talk to you about understanding depression medications and why they sometimes fail. Today we're going to kind of jump right into it. We're going to talk a little bit about depression. We're going to talk a little bit about medications, and we're going to explain to you, if you're down, why medications sometimes aren't always working the way that we would expect. I'm not going to take you through a lot of different things, but at the end of the day, I'm going to explain to you what we're going to tell you. Basically, I'm going to tell you what I'm going to tell you. I'm going to then tell you, and then I'm going to tell you what I just told you, if you follow what I'm saying. So as we kind of get into the aspect of talking about medications, first of all, the thing that you need to understand is that if you or someone has depression, that you're not alone. Depression is fairly prominent and has only been increasing post-COVID. So what we see is the following: is there's a number of different major depression is on the rise among everyone, new data shows. And we take a look at the COVID-19 pandemic, and it's increased depression rates considerably across both age groups as well as gender. And within that, it has done nothing but cause challenges in a whole host of different ways. So let's talk about medications as a whole and how do they work and function. Well, really, they're based off of 3 different neurotransmitters and modulating those neurotransmitters in different ways. So what are those neurotransmitters? Those neurotransmitters are dopamine, norepinephrine, and serotonin. And I know right now it's starting to get fancy already, but just bear with me. It is science, right? So we are going to explain that science. We're going to make sure that you understand it. We're going to make sure that you get where I'm coming from so that you can really be able to take something away. But hold on a minute. I'm just getting started. So within that context, we're going to explain to you what these different neurotransmitters do. So dopamine helps with decision making. It helps with sensations of pleasure and reward. Norepinephrine, it is influential for alertness and function. And serotonin, it helps regulate mood, appetite, and sleep. So those things are critical in terms of being able to function appropriately. The next cartoon graphic has a whole host of science that's in place, right? It's going to show you the synaptic cleft and how the medicines that we're going to talk about influence the synaptic cleft. What the heck is the synaptic cleft? So the synaptic cleft is where one neuron talks to another neuron. And we're going to explain that to you so that you get it, okay? So if we take a look, we can see this green structure at the top and this blue structure at the bottom. And they have various different receptors that are in place, okay? You can also see an orange one over there that we're going to talk about a little bit later. But at the end of the day, the thing you can see is that there's glutamate, which is one of the neurotransmitters that we didn't discuss, but is critical for there being conduction or electrical signals present in the brain. When you have different different antidepressants like monoamine antidepressants, they influence one area. If you take a look a little bit further down, you can see that there are others that influence other things. So like selective serotonin reuptake inhibitors and SNRIs influence things that are a little bit further down that deal with receptor function and such. The other things that are not traditional antidepressants, things like ketamine or sometimes medications like scopolamine, they affect different receptors that come from a different vantage point that have influences dealing with GABA. So I know that's a lot, but at the end of the day, what I want you to understand is that those things are critical in terms of understanding how and why medications work and why they don't work. So if you really had to be able to kind of get this understanding of, does this make a difference? The reason why it might work or might not work is very dependent, if you would, upon how that synaptic cleft functions, how the neurotransmitters are received, and what is done to be able to influence it. So let's talk a little bit about each receptor and how that makes a difference. So one of those receptors is, one of those medications is the following. It's a tricyclic antidepressant, right? So this is an older school class that basically has a number of different medicines, but you can think about things like imipramine or medications like chloromipramine. And what they do is they deal with those neurotransmitters that we talked about before. They inhibit reuptake of epinephrine and serotonin. And because of this, they can be able to have a number of influential components that improve mood. But some of the side effects can be pretty serious, and they aren't as frequently used. For those patients that have both depression and pain, you can see different medications like Elavil would be an example that has utility in both the pain world as well as also in depression, but it's not used quite as much. Another class of medications is the SSRIs, which I made mention of before. So SSRI stands for selective serotonin reuptake inhibitor. I know that that's a lot. I understand that it's a lot. Bear with me. I'm going to explain it to you so that you definitely get it. And so that way you're following along. i.e. that you're tracking me the same way that I hope I'm explaining it so that you can follow and understand it. Okay, so selective serotonin reuptake inhibitor. What does it do? What it does is that it influences and inhibits the reuptake of serotonin, which in that synaptic cleft that we talked about before is critical to having different things function. So, what are some of the selective serotonin reuptake inhibitors or SSRIs? They're going to be things like Prozac, Zoloft, Celexa, Paxil, Lexapro. These are things that I'm pretty sure many people have heard about. They're used with more utility nowadays and one of the more prominent classes of medications. So they really have an impact. What are SNRIs? Well, SNRIs are serotonin norepinephrine reuptake inhibitors. So let's go back. SSRIs are selective serotonin. SNRIs are serotonin norepinephrine. And again, I know a lot of this is explanation of like these different classes and they're using fancy names, but we really want you to understand this. So this way you can understand why this may or may not have value to you, right? So what are some of these medications? These are going to be medications like Effexor and Cymbalta, and they inhibit both serotonin and norepinephrine reuptake. So to go back and talk about this a little bit, these were the neurotransmitters that we made mention of: dopamine, norepinephrine, and serotonin. And you can see how these latter classes of medicines have influence on these two elements, norepinephrine and serotonin in particular, and that's what's able to improve mood. So when we look at that, are there things that can be able to prevent us from understanding how and or why this might be the case? Yes, and so we have a number of different papers. For those of you who follow our channel, we know, rather, I hope you know, we give you the references so you can be able to write this down, take a snapshot, look at the video later, and then come back to the original literature and look at it for yourself. So that way you can reference what it is that the heck I'm talking about and then say, yeah, when I take a look at this, I understand this. Or when I give this to my doctor, my psychiatrist, my psychologist, my social worker, whomever is helping you, they can be able to look and reference some of the same material. So that way you feel like you're getting true value and you can really be able to see it, not in just a quick blurb of what we're talking about today in the video. So one of the references that we're about to refer to is the following. It is derived from an evaluation of the comparative effectiveness of second-generation antidepressants and the pharmacologic treatment of adult depression. Again, I know it's fancy words. I get that it's fancy words, but we're going to explain to you and explain it to you so you understand it. And that's exactly what we're going to do. We're going to explain it to you so as if it's from the very basics and beginnings, not that you're not capable of understanding things, but breaking it down so you get what it is that I'm saying. So we take a look, we can be able to see that there's a listing of different medications that we made mention of before that can have a number of side effects that are associated with them. And these side effects, as many patients know who take medications, have said, you know what? I can't continue to take this medicine because it's causing me too many problems. And if you can't take the medicine or you can't take it with regularity, it's certainly going to affect its effectiveness, its utility, and how you feel. So let's look at the likelihood of side effects and when and where those side effects might occur. So the first is looking at medications like Wellbutrin. About 6 to 8% of patients can get things like a change in sexual side effects. They can get an increased risk of seizures at higher doses. Medications like Celexa can cause issues with changes in heart rhythm at higher doses, and that's about 5 to 9%. Medications like Pristiq can cause increases in blood pressure, which can be symptomatic, where you feel changes where you feel either lightheaded or you feel a different sensation than what you normally would, right? So medications like Cymbalta, 3 to 13%, have been associated with changes in the liver, have also had problems with patients who consume alcohol can have increases in blood pressure and other things. So these side effects can be problematic. Looking at a few more, these are some of the other side effects that can occur. So you can have issues with a medication called Remeron. About 10 to 17% have some issues with increased weight gain. It can cause some drowsiness, and it might be able to help with some sleep. Paxil can cause some issues with sexual side effects, and it's about 7 to 16%. Zoloft can cause issues with diarrhea. Effexor can cause issues with nauseousness and vomiting, and causes changes in blood pressure and heart rate. So all those type of things that can cause changes in blood pressure, cause changes with palpitations, things like that are going to influence whether you use that medication or not, right? But there is something that is called treatment-resistant depression. So what is treatment-resistant depression? So treatment-resistant depression deals with the context of depression that hasn't or won't really respond to medications the way that we expect. And I know we have some questions coming in, but give me 1 second. I want to talk about one study that I want you to take a look at, which is key. So there's a study that was published actually a number of years or so ago now, clearly almost about 15 to 16 years or so, that is published in the American Journal of Psychiatry, that was the acute and longer term outcomes in depressed outpatients requiring one or several treatment steps, the STAR-D report. If you got a chance, take a quick snapshot of this or write it down. And there's a reason for it. And one of the main reasons for it is because it actually has impact. Give me 1 second. Let me take a look at this question. Okay, it looks like we have one of our patients saying, hi, hello, Ms. Woods. We always appreciate you joining us. And the rest of you who are joining us live, we really appreciate the support. Those of you who are watching us at a later date, please actually submit your questions that you have as well. We'll be happy to try to answer that to the best that we can. Okay, so continuing on, that STAR-D report has a number of different things in it. And one of the things it talks about is the areas of depression and really how that depression component has not always responded, particularly when using medication end over end and saying, well, it's not working. Let's add another particular medication to see if it's going to give value, right? So I think the summary is the following. So skipping past the areas of the results, let's just look at conclusions really quickly, right? What it states is when more treatment steps are required, lower acute remission rates, especially in the 3rd and 4th treatment steps, and higher relapse rates during the follow-up phase are to be expected. And then it goes on to make some recommendations. So what does that mean? What that means is that sometimes when you're adding another additional medication, it's just going to be challenging with really being able to get that value. Now, we're going to talk about, there are some studies that have looked at adding additional medication or adding medicines that aren't quite the traditional antidepressants may be able to show value in a lot of different ways. But at the end of the day, I want you to understand that there are challenges with saying, well, we're just going to add another medicine or we're just going to increase the dose, and then automatically you're going to feel better. It doesn't always work that way. Many times it does not work that way at all. So what we want to do is to make sure that you understand exactly how that fits and how you can be able to utilize it, sometimes for the better, but sometimes not. Okay. So continuing on, we want to kind of take a look at another article that was a following. And this one really kind of gets in a lot of detail. It's about 150 pages or so, give or take, but kind of summarizing it so that way we're not having you here listening to me drone on all day, is the pharmacologic interventions for treatment-resistant depression in adults. And what this study is, it takes a Cochrane report, which is an evaluation of meta-analysis. So it looks at multiple different studies and it tries to summarize the data, which sometimes can be not that exacting, but sometimes it can be incredibly useful. So what we're doing is trying to give you some pooled understanding of exactly what that means. Okay, so in regards to that, one of the things that we want to kind of do is kind of take this step by step. So one of the things that they looked at is 10 randomized controlled trials with 2,731 participants. And in essence, what they did is they looked at what happens when you change to a different antidepressant, what happens when you add a second antidepressant, and what happens when you add a different type of medication, i.e. something like an anti-anxiety medication or an anti-psychotic, right? And so bear with me as we kind of go through some of these, and they're a little bit text rich, but I want you to understand. And again, just to reiterate, it's coming from this, the Cochrane Library with Pharmacologic Interventions for Treatment-Resistant Depression in adults. So One of the things that's made mention is by 2030, depression is predicted to be the leading cause of disability in high income countries. And so that I think is both scary and a bit reaffirming that there are many people who are suffering with this problem and this issue, and having challenges with medication is not uncommon. So there is going to be advancements, and there's also going to be better understanding than what we have right now about how depression can be treated. But as we kind of go through this, let me kind of give you the solace of knowing there's other people that are fighting this battle in this fight. So one of the things that they looked at was the aspect of augmentation by augmenting an antidepressant with a second antidepressant. What they found is that it can be beneficial, but it's not consistent across different drugs. And so sometimes when you add a different medication, it's really kind of luck of the draw. Further in the report, the things that they found is that switching to a different antidepressant was somewhat beneficial compared to placebo. However, the impression of this evidence was moderate quality because it wasn't always that precise. So you can try switching to a different medicine, but sometimes it's just not going to get the trick done. And no evidence was identified for other treatment strategies, such as increasing the dose of an existing or augmenting with medications like lithium or beta blockers. So all of those things, when we talk about depression, that would be kind of like the sort of shoot from the hip of like, all right, it's not working, let's do something else. Well, maybe that works, maybe it doesn't. So another article that's less scientific but more kind of evaluative talks about treatment-resistant depression and why depression meds don't always work. And what they found in kind of summary is the following: is one is that maybe the aspect of the dosage isn't just going to do it, right? And it doesn't matter whether you're using an SSRI like we talked about before or an SNRI. If it doesn't do the job, sometimes you just got to do something different. The thing that I think is important to understand, again, let me kind of say this. The thing that I think is important to understand is that a medication, particularly like a depression medication, is not going to work immediately. It's typically going to take anywhere from 6 to 8 weeks. So if you think it's going to work immediately, it's not going to be the case. It's going to take a little bit of time. So you got to be a bit patient before you talk about switching from one medicine to another. You have to understand that you got to say, all right, well, where are we with this? The other things that can be an issue is that you have medications that are interfering. So things like blood pressure medications, antibiotics, sometimes even steroids can change how those medicines work, particularly at the synaptic cleft. And then finally is, do you have other medical problems that are causing issues? And this speaks to our cross section of patients, which we deal with patients that deal with mental health and suffering on that side. And we deal with patients that have physical pain and issues with musculoskeletal issues and suffering on that side. And what we see is that there's a crossover at times where trying to treat those areas are really challenging. And you can see medical problems like hypothyroidism, chronic pain, hormone imbalances, and addiction can cause issues with really depression medications working like how we would expect or hope for them to do so. So with all that, we really have to kind of figure out what really makes sense, right? So when we think about kind of that element of treatment-resistant depression, meaning depression that doesn't respond to medications as how we would normally expect, we have to come up with some different type of strategies which may be personalized. And again, I'll repeat that, may be personalized. It's not going to be the same for your neighbor or for your colleague or for someone else down the street or family member. It's really going to have to be tweaked. There are some thoughts about some studies that have looked at the genetic predisposition of how well medicines might work. And there's a few different companies out there that are doing it. We're actually utilizing some of those companies so we can have a little bit of an advantage. But some of the studies to date have not shown a clear statistical significant advantage of saying, okay, doing this is automatically going to give you the result that you want. More so, it's suggestive that it's going to give you the result that you want. Okay, I think there's a few different questions that are coming in, and some of which I would probably say, well, let me just kind of pop the question up. So the question about why don't psychiatrists know this? I think there's some psychiatrists that certainly do know this. And many of the articles that are published and I'm referencing are in the American Journal of Psychiatry. They're referenced in the psychiatric literature. And I think there's psychiatrists that know this. And I'm not going to sit here and pan every psychiatrist. I think that there's different docs that think differently about how they would progress. The question is do you have the rapport to have that conversation? Who's helping you from a clinical standpoint? And hopefully you do, where those individuals are able to kind of sit down and tell you not just what they're going to do, but why they're going to do it. And then what's the next step as a potential plan if what we're trying doesn't necessarily work. And I think that that's pretty darn important no matter how you're getting healthcare, whether it's dealing with things like your heart and blood pressure, whether it's dealing with a neuropathic problem like a nerve pain issue, or if it's dealing with things like how you feel. I think all those things kind of matter of bringing you, the patient, into play of saying, well, this is what I'm thinking and what I'm feeling. How are you addressing this? Not with just one initial step, but what's the plan of how this is going on long term, right? So back in context, there are different ways to augment depression. And I think and augment, what I mean is augment your depression medication's effectiveness. So pardon me. So let's kind of get into that. So this is a different paper that looks at how can you be able to improve the aspect of antidepressants by using augmentation, which basically means instead of adding a depression medication, maybe you can do some other things. Could you potentially use an antipsychotic, a lithium or thyroid hormone? And I think this gets a little bit more depth and detailed. And like I said before, again, this is very personalized. And so you really need to have that conversation with the person who's helping you and whether they think this is going to be useful or whether it's going to be harmful, right? And so some of these things, I think we need to kind of have a very open conversation. It doesn't mean that just because this paper made recommendation of this, that it's automatically going to work or that it's going to be right for you. But one of the things that they make mention of is first line therapy of antipsychotics, lithium or thyroid. Second line might be things like celecoxib, which is basically Celebrex, modafinil, benzodiazepines potentially, but we want to be careful with that with utilization of other things. And then some utilization, but the evidence isn't really strong. And so let me be clear, the papers are going to say that evidence isn't really strong. However, I think the thing that needs to be evaluated is, so what is the potential downside? And many times we'll look and say, well, if we add this supplement or we change this dietary piece, it's not proven to work. And the contrary, I think, argument that really has somewhat been lacking at times is that, okay, we add this supplement, we add this element to the diet, how is it going to cause a problem? And even if it does not give benefit, things still stay the same. But if it does give benefit, maybe there's some value. I think the thing that needs to be clear is honesty and being able to tell patients, hey, this is what's going to possibly happen, but it very well may not, as opposed to standing on the ground of saying, you do this and we know it's going to work. I don't think that's proper, but I do think saying, okay, this is the context and there's not evidence that pushes this, that shows this the same way that others might. So some of the mixed or kind of not really prominent evidence are things like folate, omega-3s, doing things like lamotrigine or Lamictal, or using other types of medications like non-benzodiazepine, hypnotics, potentially looking at estrogen and testosterone replacement as a potential value that's in place. So that's one of the ways to be able to deal with treatment-resistant depression. And bear with me because we're kind of getting towards the end. Hold in there for just a little bit longer. I know it's a bit tough. I know it is, but it's going to be hopefully a value so that you can say, you know what? Yes, this is better than what I thought it was going to be. It's not going to be as challenging, and that we'll be able to kind of get you through it. Okay. And hopefully you might think it's maybe a little bit fun because I was able to explain it in a more understandable way. So one of the other ways to be able to kind of deal with this besides augmentation is switching, right? So there's a lot of text that's present here, right? But if you follow along at the very bottom of this, it talks about little evidence exists to guide the clinician's decision to switch to a medication within the same class or to try a medication from a different class. So as you recall, we talked about things like SSRIs and SNRIs. So sometimes when those medications are switched, it's really just trying to figure out, is this a fit for you? Are we having side effects that are causing you not to use the medication quite as much? Are there things where it just doesn't seem to be effective? And we're just going to have to try something a little bit different. But the clear statement of choice is really the following: is there's not literature that says, okay, monoamine oxidase, not the choice. We're going to switch then to a TCA, or, an SSRI. We're going to switch to an SNRI as a potential choice. It's not that clear. It's not that cut and dry. And I think really it has to do with that clinician's experience with using that medication and the context and how they're using it. Meaning, for you, are there certain things we need to be concerned about? Do you have a thyroid problem? Do you have a potential hormone problem? Do you have an issue with cardiac or pulmonary issues that we need to be worried about? So those are going to be some of the things. Other strategies are the following: is, can you be able to look at a combination? And so we talked about this a little bit before, but combination therapy refers to the use of 2 or more antidepressants from 2 different classes to form a broader spectrum antidepressant. And what it says is that increases the probability of positive antidepressant effects through synergism. So what exactly is synergism? So synergism is the following. Basically, if you said 1 + 1 = 2, that's additive. And in synergy, it's 1 + 1 = 5. So you get a better outcome. And why do you get a better outcome? Because kind of going back to our areas of, hey, this is science, is that we're taking a look at the synaptic cleft that we referenced previously. And we said, okay, you got these channels, you have these things that we're impacting. And if we impact one thing, the same way as what we use with SSRIs, maybe if we go to a different class that changes how there's uptake and differences in release, or we look at another potential option like things over here that uses a completely different pathway, we get a different result. Now, does that mean that that's always going to happen from patient to patient? No. But is it a possibility? It is. So who is more likely to have issues with trying to use depression medications and them not necessarily fitting? Well, these are some of the risk factors. So if you've had multiple episodes of depression before, if you happen to be more mature, if you are a woman, if you've had issues with chronic pain, if you have issues with substance abuse, sleep disorders, bipolar or post-traumatic stress disorder, it's a possibility that you're more likely to have some of those challenges with medication and them being effective. Now, what I would say to that is that does not mean hope is lost. When I'm normally in my regular office, one of the things I have behind me is hope. And what we want to be able to give you is options so you understand there is hope that's out there. Not false hope, but real hope of there are ways for us to be able to improve and help you be able to punch pain in the face and get back to leading the life that you deserve, whether it's physical pain or whether it's mental and emotional pain. I think there are ways for us to be able to be successful. And some of those things are the following: is, can you be able to look at other things outside traditional treatments? And there's some interesting things in data. Let me be clear, though, much how we talked about some of those other things that are not robust in terms of their science, I think right now it's still burgeoning in terms of certain different treatment options that don't have strong, decades-long evidence that support it. But there are some that have statistical significance. So let me be clear. As we take a look at some of these strategies, you have to kind of evaluate them and see, does this make sense for you? So one of which is ketamine and esketamine. We've had a number of different talks that have we've kind of put forth on our channel. If you're interested in it, you can check out this video in particular, which talks about the different forms of ketamine. Ketamine and esketamine are, one is an IV formulation. Esketamine is an enantiomer of ketamine, which we explain what the heck that means, which is Spravato that uses an intranasal type treatment option. And that's one way to be able to kind of deal with the aspect of depression. And then almost kind of put in place one of our patients that says, thanks God for TMS. We're going to talk to you about what is TMS and what does that mean without going into too much detail, because we're focusing on kind of depression medications, right? But to kind of reference back to that, sitting in that same area is the utilization of TMS, which stands for transcranial magnetic stim. So what is that? Well, one of our previous videos actually explains that in depth and detail, and that's Getting Your Life Back. That shows one of the chairs that's utilized in order to deal with that, and how there's, on the right-hand side, changes in the neurotransmitter from, on the very right, poor neurotransmitters in depressed state to non-depressed state, with there being an increase or a more prominent amount by looking at kind of like a PET scan or functional MRI to be able to assess it. So what are some of the other things? Well, there are things like Botox, which is interesting to be able to utilize for depression, ECT, which many people are concerned about, but there is some significant science behind ECT, which stands for electroconvulsive therapy. It's a short treatment. It is not something that's ongoing. And most of the time, those treatments are used with sedation so that you're not aware. And what I mean by short treatment, meaning in each episode, it's not something that you experience for a long period of time, but there are a number of sessions that have to take place. In addition, things like microdosing and other antidepressants that are coming out that operate under different functional classes than the ones that we talk about right now. So I told you what I was going to tell you. I told you what we wanted to talk about. Now let me kind of reiterate. So going back, these are the things that are important, right? So number one, I think you need to understand that depression is pretty prominent. It's present in many of the different states. It's present throughout the world, right? So in you having this problem or having someone that you love or care about having this problem, you're not alone. Of those patients, on rough average, anywhere from 25 to maybe 30% of patients have difficulty with medications actually working, meaning so they have treatment-resistant depression. And so in dealing with that, you have to kind of look at it in different ways. So the different ways to be able to look at it is you can be able to look at things like augmentation, where you add a different type of treatment option, not just the antidepressant, to be able to provide value. You can be able to look at switching from one medicine to potentially another and see if it gives you value by changing the class, but that also doesn't always work. You can look at combination of different classes, which may or may not work by approaching it in a different way to get a synergy. You want to understand what your risk factors are and understand how likely you are to be able to have treatment-resistant depression. And in summation of all that is understand that although traditional antidepressants may provide value, there are other things that are out there that may as well. So things like TMS, things like esketamine, things like IV ketamine, things like ECT. And there's some other interesting burgeoning treatment options that are out there that I think provide hope and let you be able to get back on your feet, let you be able to be functional. And we hope that if there's a provider that's near you, they can find that way that you are able to get a true, sincere rapport so you can get a personalized approach that helps you be able to punch pain in the face, whether it's physical or whether it's emotional or mental, and get back to leading the life that you deserve. Thank you so much for joining us and have a great day.